So, thank you, organizers. So, we are running very late, so I will, you will be very quick, I think. Current treatment landscape in first-line urothelial cancer. So, I invite Dr. Ashish Joshi, who is consultant medical oncology and hematologist at Nanavati Super Specialty Hospital, Mumbai.
Good evening. I think we're running short of time and I have another talk to be given at 5 o'clock. So I think this audience would not require too much of elaboration on the first line urothelial cancer management. So I will quickly move on just to give you some perspective as to large number of patients who have a initially seemingly localized disease are eventually going to progress. And almost 70% of them are going to have a distant metastasis. Also, 5% of patients have a de novo metastatic disease. So it's a large disease burden still hovering there. And if you look at the AJCC staging, stage 4 or advanced urothelial cancer could be divided into 3 parts: is stage 3B, stage 4A, and stage 4B. Now, mind you, stage 4A are the one where there is only nodal metastasis, and they are treated little disparately than what a stage 4B disease would be treated, somebody who has got an extensive disease. The intent of treatment for stage 4A and some of them could still be curative, and there could be some role of definitive chemoradiation still there. But of course, the current talk would focus only on the stage 4, which is non-lymph node distant metastasis situation. We know that metastatectomy has shown some survival benefit, though the surgery is pretty skillful. We need carefully selected patients, but there is a data to support that metastatectomy in oligometastatic disease could improve survival. If the evidence of spread is very limited to the nodes, then it's very important that we biopsy them and confirm whether it's actually a stage 4B disease or it still hovers in stage 3A, 3B, and 4A, because the management is slightly different. And it's one of the most mutant tumor to have known to mankind. So almost, if you do a NGS, there will be 2.6 clinically relevant genetic alteration which would be found in an NGS report. So it's worthwhile, or it's prudent to perform a next generation sequencing on a histopathology specimen. You are likely to find some actionable mutation, as we will discuss down the line. Some broad scheme of things: chemotherapy in first line is what going to be one slide. ICI post-chemotherapy maintenance, there is a separate talk, so I would not dwell too much into it. And the last important is immunotherapeutic agent, first line, when and how. So these would be the 3 compact discussion on which I would keep my focus on. So chemotherapy first line, again, audience does not require any further elaboration. GC is equal to standard MVAC in terms of efficacy. GC is far better than MVAC in terms of toxicity. DD MVAC is far superior to standard MVAC in terms of efficacy and toxicity. Carboplatin can replace cisplatin in a cisplatin ineligible patient. And addition of third drug like taxanes has got a lot of questionable benefits. So if you're actually talking about first line trial in terms of chemotherapy, these 5 particular points would actually summarize as to where we stand in 2022. And I do not see a lot of change happening in the chemotherapy landscape as far as the first line therapy of urothelial carcinoma is concerned. Then comes this concept of avelumab maintenance. I would not dwell into too much of it, but there is a Javelin 100 trial, overall survival benefit again for patients who had received first line of cisplatin based therapy, and those who had a stable disease or a partial response went on to receive avelumab maintenance therapy, and then it has shown a survival benefit. So that again continues to remain one of the important treatment algorithm in the treatment of first line advanced urothelial carcinoma. Now, the most important question, of course, that has been is ICI, first line, when and how. How do you define platinum eligibility, patient selection, and what is the evidence and action as far as the immunotherapeutic agents in the first line setting are concerned? So these are classic criteria which we typically used in the clinic: creatinine clearance, auditory hearing loss, heart failure, performance status, and peripheral neuropathy, and with which almost half of the patients which we see in our clinic would be cisplatin ineligible. And how do we approach this patient is the question that probably we need to answer. Again, some very basic facts: that decreased survival when ICI first line monotherapy compared to those receiving cisplatin or carboplatin based therapy. So the jury is pretty clear here that do not use IO first-line monotherapy if you have a patient who is either cisplatin or a carboplatin eligible. You did not have choose chemotherapy only for PDL1 high platinum eligible patient. We do not do. Somebody who has got PDL high score and is platinum eligible, still use chemotherapy, don't use IO. Then one would wonder, do we need PDL1 checking at all? Yes, we will use it for atezolizumab, which I will discuss subsequently. And chemo plus ICI is no better than ICI monotherapy alone. So if you're looking at, if you have a cisplatin or a carboplatin eligible patient, then first line therapy would be chemotherapy. If you have a cisplatin ineligible patient or a carboplatin ineligible patient, then we will see how we could include atezolizumab or pembrolizumab in the first line therapy. So this first line data of atezolizumab has come from two trials, IMvigor 2, 110 and 130, and the pembrolizumab has come from Keynote 052 and 361. We know this study design, IMvigor 210 is a phase 2 single arm study. The focus, of course, was response rates, standard criteria which were there. And if you could see, impressive response rates of almost 40%, 30 to 40%, with a 2-year overall survival of 41%. Again, fairly decent subgroup of patients. It also included patients who are elderly, and as we typically see in most of the ICI agent, is the duration of the response, which is the selling point for all ICI drugs. And those patients who had a response, they had a long duration of the response, which probably translate into an operational cure in some of the patients, as you could see here. The patients who were elderly, typically cisplatin ineligible patients, also did show response, and the toxicity was favorable, and there was improvement in the quality of life. IMvigor 130 went on to study whether atezolizumab monotherapy versus atezolizumab plus chemo versus placebo would be better. Again, primary endpoint was investigator assessed PFS and OS. And if you could see in the curve subsequently, in the arm A, where there was a comparison between atezolizumab plus platinum-based chemotherapy versus platinum gemcitabine plus placebo, there was a difference. But when you start comparing atezolizumab plus chemo versus monotherapy with atezolizumab, the difference was not very conspicuous. Again, coming to the fact that subsequently there was a withdrawal of atezolizumab combination, and it is only now restricted to the patients as a monotherapy who are cisplatin ineligible and who have got PDL1 score of 5%. So as far as the atezolizumab first line is concerned, it is only to be used for patients for whom they are not eligible for cisplatin containing chemotherapy and whose tumors express PDL1 as by TPS score of 5%, and they'd use SP142 as the platform. Or they could also be used in the patients who are not eligible for any platinum containing chemotherapy regimen, regardless of the level of PDL1 expression. So typically, if you have a patient who is not eligible for cisplatin but eligible for carboplatin, and that's where you have to decide whether you want to use immunotherapy or no. Maybe PDL1 score would help there, and if you have a PDL1 score more than 5%, then you are justified using atezolizumab as a monotherapy in the first line setting. Coming to the pembrolizumab, again, two studies which I had mentioned before. Keynote 052, it's a single arm phase 2 study, again, to analyze the duration of response. And if you could see, similar story continues in most of the IO agent. Those patients who had a response had a long duration of response. There were impressive PR and CR rates, even in patients who are typically high tumor burden disease. Toxicity again was main manageable. This is again the progression for survival curve and the response curve, which has been mentioned in the Keynote 052. So these were the first line combination trials. Again, as I had mentioned to you before, that IMvigor 130 and Keynote 361. These were the two trials which studied monotherapy versus mono plus combo versus placebo. And I think the jury is out here that monotherapy is far superior. There is no benefit of adding mono plus chemo in the first line combination of advanced urothelial cancer. So the indication of first line pembrolizumab, because the survival inferiority of the survival when used in a cisplatin eligible patient, now pembrolizumab could only be reduced to patients who are not eligible for any platinum containing regimen. Somebody who is eligible for carboplatin, then probably carbogemcitabine would be a better option. Again, head-on comparison, first-line immune checkpoint inhibitors, pembrolizumab, atezolizumab. I think I have sort of given the brief about it, so I would not waste my time belaboring it here. This is a management algorithm as we stand today in 2022. The patients are either cisplatin eligible, carboplatin eligible, or platinum unfit. And those patients who are cisplatin eligible and carboplatin eligible will actually end up receiving chemotherapy as a first line treatment because it is better than ICI alone. Only those patients who are platinum ineligible or those patients who are carboplatin eligible but who have got PD-L1 of 5%, then these are the patients wherein you could use first line immunotherapy based on Keynote 360 and IMvigor 130 study. And subsequent to the therapy, how they will progress, that's something which I would leave it to my next speaker who is going to discuss about the second line therapy as far as the advanced urothelial cancer is concerned. There are a lot of new studies which are currently ongoing and many trials are recruiting patients for advanced urothelial carcinoma. I'm sure you will have answers to many of these trials soon. And it would be interesting if we could find some second line or third line agent coming back into the first line space and probably improve the outcome for these difficult to treat patients. So this is in a nutshell how we look about cisplatin eligible patient, gemcitabine cisplatin or or DD-MVAC also is a reasonable option. Patients who are platinum ineligible, completely ineligible, then these are the patients wherein pembrolizumab and atezolizumab can be used regardless of the PD-L1 expression. And I thank you for your patient hearing. Thank you.